Hello, my name is Susan Onyango. I am a nutritionist in Marindi Sub-County Hospital in Homa Bay County. Now, today I want to talk about pediatric nutrition in chronic kidney disease. Infants and young children withstand nutritional deprivation less well than adults because they have low nutritional stores and high nutritional demands for rapid physical and brain development. Adolescents are also at a greater risk because of the high demands of growth during puberty. Now, when kidney is damaged, it cannot perform its functions well. Looking at etiology of chronic kidney disease in children. Chronic kidney disease in children can be caused by congenital, hereditary, acquired, or metabolic disorders. Congenital causes are the most common and include abnormally developed kidneys, for example, plastic, hypoplastic, and dysplastic, and obstructive neuropathy, for example, posterior urethral valves. The second most common cause is acquired conditions such as chronic glomerulonephritis, membranoproliferative glomerulonephritis, or focal segmental sclerosis glomerulonephritis. In contrast to adults, diabetic kidney disease and hypertensive nephrosclerosis are uncommon in children. So we are going to talk about staging of chronic kidney disease in children. In staging, we use a glomerular filtration rate, which is GFR, and this is a test of how well the kidneys function. So we have 5 stages. So in stage 1, when GFR rate is equal to or greater than 90, then we say that it's a normal, or there's normal or increased GFR. In stage 2, the range is between 60 to 89, and here what we mean is that there's a mild reduction of GFR. In stage 3, it ranges between 30 to 59. So this one means that the GFR is moderate. There is a moderate reduction. In stage 4, there is a 15 to 29, the GFR rate, and here is severe reduction of GFR. And lastly, stage 5, which is less than 15, we term this one as kidney failure. Let's talk about nutritional care for children with chronic kidney disease. So, goals of nutritional care is the maintenance of optimal nutritional status. In this case, we want to achieve normal pattern growth and development by intake of appropriate amount and types of nutrients. We also want to avoid uremic toxicity, metabolic abnormalities, and malnutrition. Another goal is a reduction of the risk of chronic morbidities and mortality in adulthood. In nutritional care, we first do nutrition assessment. Here we have to know a medical history of the child, the medication that the child is on. We do dietary interview, and here we can do a 24-hour recall. We have to know the required intake for the child and even the physical eating skills of the child. Under growth parameters, we do a height, length for age Z-score, weight for age Z-score, estimated dry weight, weight for height Z-score. And we also do head circumference until the child is 3 years old. Then we look at the lab values, and especially serum albumin and serum bicarbonate. We also look at the change in GIT function. So for monitoring of growth and nutritional parameters depends on the age of the child and the stage of the kidney disease. It should be done frequently, and as twice frequently for the healthy children. Let's talk about dietary recommendations. Number 1, we are going to look at energy requirements. So energy requirements are similar to those of healthy children. However, children with protein energy wasting require more. Adequate calories are important for weight gain. Adjustment of energy intake is dependent on weight gain or weight loss. And to increase energy, you can add extra oil to food, for example in rice, even porridge, vegetables, and so on and so forth. Supplemental nutrition support should be considered if usual intake does not meet energy requirements. When we talk about protein requirements, first there is high biological value protein, that is from animal sources, and low biological value proteins, and that is from plants. Both proteins are required, but high biological value proteins is required from about 50 to 70%. Another nutrient to consider is phosphorus. After initiation of dietary restriction, monitor serum phosphorus every 3 months. Then take phosphate binders in pills. Another nutrient to consider is potassium, and intake of potassium should be limited. Some of the rich sources of potassium include banana, avocado, oranges, and root tubers. You can also leach vegetables to reduce potassium. Considering sodium, if it is in excess, it may lead to high blood pressure and fluid retention. Therefore, it should be restricted for children with hypertension. Fluid intake should also be restricted for oligoanuria to prevent complications of fluid overload. In Homa Bay County Referral Hospital, we have renal unit. And here with us today, we have the acting county nutrition coordinator who will help us understand the situation of the renal unit in the county. Yes, Mr. Cage, is the renal unit in the county fully functional?
Thank you so much, Susan. At the moment, we have resumed services which were temporarily stopped.
A renal unit, are there enough nutritionists?
Apparently, we don't have enough nutritionists in our renal unit, but at least a nutritionist is assigned for the renal unit.
In summary, we have looked at etiology of chronic kidney disease in children, staging of chronic kidney disease. We've also looked at goals of nutritional care, the components of nutritional assessment, and dietary requirements for children with chronic kidney disease. We have also learned from the acting CNC that the renal unit is now fully operational. Nutrition care is important for these children to ensure optimal growth and also to slow renal disease progression. Therefore, a multidisciplinary team comprising nutritionists, nurses, doctors, social workers, farm techs need to work together in management of pediatric renal cases. Thank you for your time. I believe that this is the opportune time to have a trained renal nutritionist to offer specialized services to renal patients, including pediatric patients.